and the practical aspects, when to refer and what can be done by us. So it's a pleasure to introduce Dr. Shambhavi. She's an old member of us. She's been taking active interest in all our meetings, especially when it concerns developmental pediatrics. So Dr. Shambhavi is a developmental pediatrician at BL Kapoor Hospital and at Max Hospital also. She's a joint secretary in the IAP chapter of Neurodevelopmental Pediatrics. She'll be given the honorary fellowship by IAP for contribution in childhood disability and early intervention. She's also the director of Bright Beginnings in the Child Development Center since 2010, which has been catering to a variety of autism and other developmental delay problems in children. Welcome, Dr. Shambhavi, and thank you so much for being the chairperson today for our meeting. Thank you so much.
Thank you, Dr. Sandhya, and thank you, Dr. Bimal, for inviting me here today. So it's a very close topic to my heart, which is about behavioral issues and problems in children in school age. And I think everyone would agree after, especially post-COVID, we are seeing a lot of children right across all age span, whether it's a toddler, 3-year-old who's adjusting in a nursery setup, or an adolescent who is refusing to kind of study in a high school and having a lot of learning issues. We are seeing children from across all age where there has been a problem regarding different aspects of development and behavior. So to discuss the same today, it's my pleasure to introduce Dr. Shubham Roy. Dr. Shubham is a director at Shining Stars Child Development Center. She is also a visiting consultant in developmental and behavioral pediatrics at Sitaram, Bhartia Institute, New Delhi, Triton Hospital, and Venkateshwar Hospital, New Delhi. She's done her undergrad from KMC Mangalore and her post-graduation in pediatrics from RIMS Ranchi. After that, she's done her PG diploma in development neurology, and also she's completed her IAP fellowship in development and behavioral pediatrics through the IAP chapter and worked at Umeed Center. So over to you, Dr. Shubham, and good luck for today's presentation.
Thank you, ma'am, for the kind introduction, and thank you for giving me this opportunity to present here today. So let me share my screen. So I would start my slideshow. Yeah, is it visible?
Yes.
Yeah, okay. So why I chose this topic, Dr. Shambhavi has already said that suddenly there has been a flurry of cases where we are seeing behavioral concerns in school-age children, preschoolers, and sometimes we find it hard to understand where to act. So when to refer, what can be managed by a pediatrician. So like when I started seeing them being referred, so this the thought that came to mind when this offer was given to present a CME on developmental pediatrics, so why not to discuss this condition. So before I study, so let's, before I start, hello. Hello.
We can hear you.
Dr. Shubham, we can hear you. Yeah.
So first of all, we should understand what is a behavior. A behavior is the way a living organism externally reacts in response to its environment, and it's essentially anything a person does. So classically, a dead man's test has been described. So if we ask that question, can a dead man do it? If he can, then it is not a behavior. So the behavior of school-age children, it is an important indicator of their adaptation who in the stage of development. They are adapting to the needs, to the environment, and in response, they react externally. So it is an important indicator of the level or the degree of their adaptation. However, not all children are successful, and some of them may present with developmental or behavioral problems. And these behavioral concerns may be expressed within the family or in the school context or in the societal context. So, like I said, behavior is anything or everything we do. So when we talk about behavioral concerns, what we talk about are the challenging behaviors. These are culturally abnormal behaviors of such an intensity, frequency, or duration that the physical safety of the person or the others is likely to be seriously compromised, or behavior which is likely to seriously limit or deny access to and use of ordinary community facilities. And because the children who present with behavioral problems, it can cause the significant distress in the family setup. It can cause significant amount of stress to caregivers and can impair the functioning of a family. So these challenging behaviors could be categorized under two, either externalizing symptoms, which are external manifestations of behaviors, and the second type is internalizing symptoms. So some of the examples of externalizing symptoms of behavior are aggression, oppositional behavior or defiance, hyperactivity, physical assault, lying, truancy, substance abuse. The internalizing symptoms are often associated with conditions like anxiety and depression, and these may include social withdrawal, excessive fears, poor appetite, and other somatic symptoms like headaches, stomach aches, and poor sleep. So why do we need to understand or learn about behavioral problems? We should understand the burden of the condition worldwide and also in India. So I could find some older studies which have reported the prevalence to be around 12.5%. This was a study which was done at Bengaluru in the children between 6 to 16 years old. Another study which was done at Chandigarh, which included children between 4 to 11 years. And here the prevalence of behavioral problems was estimated to be 6.3%. A recent study which was done at Kanpur among school children between the age of 6 to 18 years, and there the prevalence was found to be much higher than what was previously reported across studies in India. So the prevalence was found to be 22.7%. So this, even though these figures are much higher from what has been reported earlier, these are in concordance with what has been reported globally. If we look at the figures of developed nations like Canada, Germany, and USA, the prevalence of behavioral concerns or behavioral disorders is about 18.1%, 20%, and 21%. And even these figures are older. So even though classically these preschoolers are not school-going children, however, in Indian setup, a 3-year-old is going to nursery class. So I have included these in my presentation because these are a major chunk of referrals or the children which we see. Some of the behavioral issues which are reported, or some of the common behavioral issues reported in preschoolers are temper tantrums, hyperactivity, non-compliance or defiance, school avoidance, being aggressive towards peers or their siblings. Sometimes they may even try to hurt themselves by headbanging or other measures. Sometimes they may show excessive fears and other somatic symptoms like sleep disturbances, eating too little or eating too much, throwing things, crying unnecessarily. So this list is obviously not inclusive of all the symptoms. These are some of the common manifestations. So when a child comes to us with behavioral problems, one of these problems, what should we look at when we decide whether this can be managed or whether this child requires further evaluation? So like with any other symptom which we see, we should always inquire about the onset, duration, and progression because a sudden onset condition will be different from a condition or a symptom which has arisen insidiously over the last few months. So the onset, duration, and progression should always be inquired upon. Also, it is very important to ask about the frequency of the behaviors, how intense the behaviors are, and whether it is present in one setting or more than one setting. So here by setting, I mean either in family, in school setting, or any other setting. So if a behavior occurs in one setting, it is more often because of something related to that particular setting. If it is occurring only at home or only in the family setting, it could be something related to parenting or something happening at home. So it is very important to ask where these behaviors are manifesting. And also it is very important to look at the developmental stage of a child. some of the behaviors, because all these behaviors which I had mentioned or listed here in preschoolers, some of these almost every preschooler will show some of these signs and symptoms at any particular point of time. So how to differentiate depends a lot on the frequency, intensity, and also the developmental stage of the child. For an 8-year-old child, hyperactivity may be a symptom which we should be worried about, but maybe for a 3-year-old, we should still, this could be developmentally normal if a 3-year-old is just sitting for 15 minutes, while this could be a problem for an older child. So developmental stage of the child should always be looked at. Some of the red flags that would warrant further evaluation or a detailed assessment are unpredictable behaviors where we are not able to find out what exactly is the trigger point. This behavior is occurring anytime or at any setting. These are prolonged, last for very long durations, hard to control, and these are destructive tantrums with severe outbursts of temper. They may be loss to property, physical harm to self or to others. Also, the presence of somatic symptoms like loss of appetite, sleep disturbances, or occurrences across multiple settings. These are all red flags which we should always keep in mind, because these children would definitely require a detailed assessment or evaluation. So some of the common conditions, these are the disorders, even though a preschooler can, a typically developing preschooler can also present with behavioral concerns. However, we should also keep in mind certain conditions or disorders which can present as behavioral problems in preschoolers. One of them is autism spectrum disorder, which is characterized by repetitive behaviors, which is characterized by poor social interaction and communication, along with the presence of repetitive and restrictive behaviors. ADHD, even though it presents ideally it should be diagnosed later. However, even it can be diagnosed as early as 4 years if the symptoms are severe enough. Anxiety disorders, often these the anxiety disorders, they often present with internalizing symptoms. And we often attribute these disorders to be present among the adult population. But anxiety disorders, they are one of the earliest presenting mental health condition in children, and it can be present even in a young child, about 2 or 3 year old. Some of the other common conditions are habit disorders like tic disorder, Tourette syndrome, thumb sucking, bruxism. These are some of the habit disorders which also we need to keep in mind. So I'm not going into the details of the conditions. I would now I'm coming to the common behavioral issues in school children, which is between 6 to 12 years. Some of the symptoms which the preschoolers are showing, some of these are present even in 6 to 12 years. These are some of the common behavioral issues like hyperactivity, aggression, lack of remorse, putting blame of things they do on others, lying, being argumentative with family members or peers or siblings, school avoidance, damage to property, being vindictive, pyromania, kleptomania. These are some of the common behavioral issues which can be seen in children between 6 to 12 years. And here also we should always inquire about the onset, duration, and progression, as these can give a clue to the underlying cause or etiology. And we should always ask about the intensity and frequency of behaviors, as this would be the guiding factor for deciding on the interventions. And we should also, in cases where there is a sudden onset of behavioral disturbances or disorder, we should always ask about any recent stressor, any change in family dynamics. We should also look for signs and symptoms suggestive of learning difficulties, because many a times school-age children, they will present with behavioral problems when the underlying cause is learning difficulty. They would want to avoid school. So we should also be asking about bullying, taking history about abuse, and as I mentioned earlier, presence in single or multiple setting. This is a very important indicator whether we need to do a detailed assessment for this child or whether we need to act on the setting and look at what is leading to these behaviors. So some of the common disorders which can present as behavioral issues in school-age children, like in the preschool in age group, the disorders can be autism spectrum disorder, ADHD, disruptive behavioral disorders. These disorders are often on a continuum with ADHD, And like in preschoolers, anxiety disorders. So this list is also not exhaustive. However, these are some of the common conditions which can present as behavioral issues in school-age children. So talking briefly about some of the conditions like common disruptive behavioral disorders in school children, like oppositional defiant disorder or ODD, it is characterized by an angry or irritable mood, argumentative or defiant behavior, vindictiveness. So these symptoms should be present on most occasions and should be there in a child who is more than 6-year-old for at least a duration of 6 months. Also, conduct disorder, which is also a disruptive behavioral disorder in school children. Here, the basic rights of others or the societal norms or rules are violated. It can present with signs and symptoms of aggression to people or children, destruction of property, deceitfulness or theft. Another disruptive behavioral disorder is intermittent explosive disorder. It is characterized by recurrent behavioral outbursts, verbal or physical aggression, damage to property, and outbursts are out of proportion to any trigger. For both conduct disorder and intermittent explosive disorder, these signs and symptoms should be present over a period of at least for 12 months. For both these disorders, this should be present for at least 1 year to be able to make a diagnosis of conduct disorder or intermittent explosive disorder. So there are several conditions which are grouped under anxiety disorders, and often these may be the cause of the behavioral issues which see in children, especially the school-age children. These are separation anxiety disorder. Here the child is excessive fearful of the separation from a parent. So the child would cling, cry, and often shows extreme distress. And even when the child is anticipating separation, then also the child shows extreme distress. Selective mutism is another anxiety disorder. And in selective mutism, what we see is that a child is verbal and communicating well in some settings, while becomes mute or completely averbal in other settings. Specific phobias, which is characterized by active avoidance of the triggering the triggers, which the child is excessively fearful of. Social anxiety disorder, panic disorder, which is characterized by panic attacks. Agoraphobia or active avoidance of public transport, open spaces or closed spaces. Generalized anxiety disorder, where the child may be fearful of even routine work, like going to market or going to school or anything which they do. So even when this anxiety affects almost all the routine activities, then it can be termed as generalized anxiety disorder. Some children can also show signs and symptoms of obsessive compulsive disorder and post-traumatic stress disorder. And this we should be very cognizant of, because post-COVID, the children might have lost a family member or a relative. And post-traumatic stress disorder we should actively look for if the behavioral changes are recent onset and there is a significant family history or something, a significant stressor. So how do we approach when a parent comes with concerns related to challenging behaviors? Often the question asked is whether the child is normal. This is what the parents often want to know, that what my child is doing, whether this is normal or this is an indication of certain condition. So this is the hardest part, to draw boundaries between typical development and clinically significant behavioral disorders. So this is the most challenging and difficult part. Sometimes typical development may be inappropriately identified as a problem behavior depending on the child's age. And therefore, a detailed clinical evaluation is very important, not only to identify the child factors, the family factors, the environment-related factors, including developmental or health problems, and social stressors, which could be contributing to the problem. So these are the factors which we should inquire about. The biological or the child factors includes genetic predisposition, any brain damage or early medical history or some significant birth history. It also depends on the child. Some of the behaviors may be dependent on the child's temperament or due to some chronic physical illnesses. We should also inquire about family factors like the type of family, the type of interaction between members in the family, the type of parenting. Some of the times the problem may lie in the type of parenting. So we should always take these background information while we are evaluating a child who presents with behavioral problems. Some of the school factors, like giving facilities to students who are doing better academically, this can also cause a negative impact on a child and can lead to some of the challenging behaviors. We should also inquire about the socio-demographic factors like their socio-economic status, the educational level of the parent. So these factors should always be taken into consideration when we are deciding or when we are dealing with a challenging behavior. So during history taking, it is very important to know the onset duration of the presenting complaints and the setting or the settings where the behavior was observed, whether it is occurring at home, at school, at any park or other gatherings, and what is the frequency and severity of the behaviors observed. We should also inquire about the possible triggers or the predisposing events and what were the attempts that were made to resolve the situation. A good developmental history is also very important. We should also inquire about medical history, including any medications. If possible, we should also ask the parents to bring school reports, because that could also give us a clue to the child's functioning at school. So like I said, it is important to ask about family and social background. And we should also asking this from the family about their concerns, their ideas and expectations from the treatment that would help us in formulating the intervention plan. Now coming to examination. We should, like in any other pediatric case, we should do the general physical examination and systemic examination, including a neurological examination. We should evaluate whether the child is thriving well by plotting the growth parameters and comparing them with the ones previously documented at the child's health booklet. We should also look for dysmorphism and neurocutaneous stigmata. A complete developmental assessment should be done. While we are talking to the parents, we should always make a note of the general behavior of the child in the consultation room. Is the child excessively active? Is the child easily distracted or moving quickly from one activity to another? What is the child's play like? While doing a developmental assessment, usually we keep age appropriate toys and simultaneously observe the child's behavior. We should also make a note of how the child is interacting with the physician and also their interaction with the family or the caregiver. We should make a note whether the child is interacting with the caregiver, like showing them the toys. Is he very clingy to the caregivers? So we should make a note of these factors while we are doing a developmental assessment. We should also look at the child's behavior when we are talking with the family, whether the child is able to quietly play and settle down, or is the child disrupting or intruding while we are talking. So these would give us pointers to the not only to the developmental level of the child, but also the behavioral concern which we are looking at. So if we take a good history and examination, including a full developmental assessment, about 80%, we can obtain about 80% of the information from there. So now what do we do when we decide that this child has a behavior which is actually causing problem? This child needs further interventions. So the interventions will depend on the factors, like looking at the child factors, the family factors, the societal and the school factors. So we should always look at those factors, the severity of the presentation. And one of the most important factors deciding the management part is the impact of the behavior on the child and the family. And also very important part is taking into consideration the family's expectations in dealing with the problem behavior. So some of the part which can be done in a pediatric setup is knowing the ABCs of behavior management. A being the antecedent or the triggering event. B being the behavior or the specific manifestations of the behavior. C being the consequences or the actions taken following a specific behavior. if a child shows a behavior, all of these behaviors do serve a particular function. The child engages in that behavior either when a child wants something and he's refused, or if a child wants to avoid something. Then, like if a child wants to avoid going to school, the child can throw a tantrum. So most of the behaviors can be explained by an underlying cause. Some of the times when there are no clear-cut stressors, it could be occurring because of some sensory processing issues or challenges. So knowing the antecedent or the event that triggered the behavior. So this antecedent is usually just, this happened just 30 seconds to 1 minute before that behavior manifested. So a good idea of how, what triggered the event and what consequences were taken, like what actions were taken, whether the parent gave into the child's demand, whether they refuse the demand, but sometimes they are giving into the demands. So how this behavior stopped or what actions were taken, this should always be inquired upon. So some of the general principles which can be taught to the parents, like they should model desirable behaviors. When we want to increase a good behavior, we should always provide positive reinforcement by means of a reward system or a star chart, offering specific praise for desirable behavior. For example, if a child is listening and following the instructions carefully or nicely, then we should always say good listening or something specific for that particular behavior rather than being general that well done or good job. So we should offer specific praise if we want to increase a particular or a desirable behavior. Structure, providing them a structured environment or a routine. This is also helps in promoting positive behavior. So all children thrive on structure, and especially those who have a developmental concern or a behavioral concern, for them providing a structure or a routine is very beneficial. So parents and caregivers, they need to set clear behavioral expectations from children and establish clear consequences for problem behaviors. Like when we are teaching parents about the ABCs of a behavior and we ask them that, okay, to reduce this behavior, you have to ignore this behavior. And we have to make sure that the caregivers are consistently following through the consequences. And we should forewarn them that the child's behavior may actually get more difficult or it may worsen before it begins to subside. Because when a child is not getting attention which he required by doing that behavior, the child may further increase that negative behavior for some duration. However, persistence is the key when we are trying to manage such behaviors. So like when we have, like we saw that the initial behavior, when to refer. So like some of the things can be done at a pediatric clinic where we can teach the parents about the ABCs of behavior, make a chart of the, make a diary or a chart where they can write what were the clear antecedents or the triggering events, how long the behavior manifested, what was the frequency of the behavior and how it was tackled or what did they do. So these can be done at a pediatric setup. But if a child is not responding to the initial behavioral management or parent training, then we should consider referring the child to the specialist for managing or handling these behavior and further evaluation. So there are some clear-cut pointers when we should refer the child to a specialist, like when the initial behavioral measures have failed, when the child is at risk of physical harm, either to self or to others, when this behavior is hindering the child's functioning and development, when there are concerns about an underlying medical condition, for example, sensory impairment or intracranial pathology, etc. Also, when there is strong suspicion of neurodevelopmental disorders, we should then definitely not wait and refer the child immediately. Also, if there are parental mental health concerns or issues or the family dynamics are complex, so parents might not be as engaged or involved in managing the behavior. So even in those cases or circumstances, we should be referring the children to specialists. Also, when the childcare center or a school is concerned and they are finding it hard to cope up with the child's behavior, even in those circumstances, the child should be referred for further management. And one of the most important factor or deciding factors is when the behaviors are so severe or of such intensity that it is affecting the functioning of a family. So These are the scenarios where the child should be referred for detailed assessment. So now coming to two case scenarios. So these are two similar age children, because these are some of the children which we are commonly seeing nowadays after the schools have opened after the lockdown. So this was a case of Anjali, who was 5.5-year-old girl, and she was referred to the child development clinic at Sitaram, Bhartia. She came with her parents, who were concerned that she is refusing to go to school since the school reopened after the pandemic. They reported that she had been earlier attending online classes and enjoyed them well. However, has now started refusing to go to school. When the parents try taking her to school, she starts screaming, clinging to the mother, and is eating much less. They also reported that she is eating much less from the past 4 to 5 weeks since the school started. So they were finding it really hard to send her to school. And when they asked from the class teacher about her behavior at school, she reported that the child needs to be comforted frequently, and she had to attend her frequently to soothe her and calm her down. And also she reported that she appeared withdrawn in the classroom and did not interact much. So during history, her parents reported that she had always been a shy child. They had got her admitted to a play school at 2.5 years earlier, but they had to discontinue because of excessive clinginess and tantrums at school time. And after that, COVID happened, so they did not got a chance to see this to enroll her in school again. And she had been attending online classes when she was enrolled in nursery class. They reported that she has friends in the neighborhood. She was the single child of the parents, and they reported that she has friends in the neighborhood and she plays appropriately with them. Her developmental milestones after a detailed developmental history, they were also normal for age. The parents did not report any other concerns. So during the assessment, when the child walked in with the parents, she avoided eye gaze in the beginning. She was hiding behind her mother, took several minutes to warm up. Initially, while I tried talking to her, she avoided, she kept looking down. However, when I was talking to her parents, she started exploring the toys on her own. And in between, she kept glancing at her parents and also at the examiner. Later, at my attempts to communicate with her, she started communicating well. Her eye contact also became better. She participated in reciprocal conversation and was quite expressive while she described some of the events which happened in the playground with her friends. A detailed developmental assessment was done, which showed the developmental milestones to be appropriate for age. Even an informal academic assessment was done, which showed that her academic or pre-academic skills were also age appropriate. Systemic examination was also normal for age. So what next? Shall I go with the diagnosis, or shall I say tell the next case which is similar, and then we can discuss about what I considered in diagnosis?
We'll go with the diagnosis.
Comfortable for you.
Okay. So like this child was developmentally appropriate, developmentally all right. The milestones were normal. The parents reported her to be shy child. However, when we look at this, that when the parents started sending her to school, she is also eating less for past 4-5 weeks. So when the school started, the tantrums are so severe and so intense that they are finding it hard. They are really struggling and worried about her education, whether she would be able to go. So somewhere the behavior is affecting the functioning of the child as well as the family. The child is not able to go to the school. So this behavior has an underlying cause. Considering the possibility of separation anxiety disorder, we detailed a psychological assessment for this child, and her symptoms were suggestive of separation. The scores were suggestive of separation anxiety disorder. And this child had been started on the parent training and behavioral interventions, not on any medication. We are yet to see the result because this has been a recent case. However, we went ahead with interventions considering that it is affecting her functioning and also affecting her education and also affecting the functioning of the family. So now coming to the second case scenario. So here again, this is a child, Ritvik, who was aged 5.5 years, the same age. This child was also referred to us to the child development clinic. So he came with his parents who were concerned, the same complaints, that he is refusing to go to school since the school reopened. So this is one of the commonest complaints now which we are seeing, that the child is having difficulties in going to school. So they reported that he had been earlier attending online classes comfortably and there were no academic concerns. However, now when they have started sending him to school, the first week was okay, but then he has now started screaming, thrashing, hitting parents when they try sending him forcefully to school. His class teacher had reported in the first week, this class teacher had actually called the parents and reported in the first week of school that he's not following instructions in classroom and tries running out of classroom often. They had asked his parents to get an evaluation done. So his parents also reported him to be a shy and reserved child. They did not have any other concerns when asked that whether they had any other concern. They said, no, nothing. He's apart from the school problem, they did not report anything. On inquiring in detail, they reported that there was history of speech delay in the early developmental period. The child started using single words around 2.5 to 3 years. And now they said that he communicates well and he communicates in sentences according to the parents. On asking, they also said that he liked playing with older cousins who visit their home, but he did not take interest in other children of his age. So during the assessment, this child avoided eye gaze completely. He took interest in exploring the toys. He kept playing with the vehicles. He picked up the vehicles from the toys and started playing with them. While I was talking to the parents, he indulged in self-talk, which was incoherent to the examiner. On my attempts to engage him in conversation, he was able to answer questions like what and where. So he was using 2 to 3 word phrases, and he was mostly using short phrases to answer. However, he was not initiating any spontaneous conversation either with parents nor with me. I also noted immediate echolalia on some occasions. When I asked him in detail, when I asked him open-ended questions, what I got in response was he repeated the same questions to me. So he did not initiate any conversation with parents or to me. So other behaviors noted during the consult was turning wheels of the toy car repeatedly. He kept going round and round a pillar for several minutes. And later, seeing these signs and symptoms, I inquired in detail about the early developmental history, and there were several red flags or symptoms for autism spectrum disorder. So we did a CARS test for him, and his scores were suggestive of mild to moderate autism. His literacy milestones were also age appropriate, and systemic examination was normal. So for this child, we made a diagnosis of mild to moderate autism spectrum disorder. So these were 2 cases which presented in a similar manner, the same concerns. However, on detailed history and assessment, difference was seen. And the first child had symptoms of, while the first child had symptoms of anxiety, which was manifesting, this child had autism spectrum disorder. And many of the times, those children who has autism, who have mild autism or who are high functioning and verbal, they get missed and they may present as behavioral concerns later. So here lies the importance of a good developmental history and assessment and observations. So coming to my take-home message, that behavioral problems are common in childhood, and if not appropriately addressed, they can become chronic and persist into adolescence and adulthood. These problems in children, these can be an early presentation of developmental concerns or a learning disability or mental health problem. Common behavioral problems can be effectively managed by behavioral interventions. So we can institute the ABCs of behavior management, and we can start parent education and parent training for these behaviors. And and if these interventions or what we have done, if these are not working, then we should consider referring a child for further evaluation. if these strategies fail, or if we have any concerns about the child's immediate safety or the safety of others, and any concerns related to developmental disorder, then we should always be referring these children. So, thank you.
Thank you, Dr. Shubham. It was really a wonderful presentation. And I think you brought out all the common issues and common kind of behavioral problems which we are seeing in our day-to-day practices. So something which I also have experienced is when we are seeing children and coming, especially younger age children, we are seeing more, and starting with play school, nursery or kindergarten. So I feel one thing which we really have to address is the parental concern. So even if we are looking for a behavior in a child, whether it is ADHD or whether it is autism or whether separation anxiety, those things are in the child, but how the parent is perceiving the problem or handling the problem is equally important. Because especially in younger children, I've seen the way the parent is handling can really lead to foundation of further issues or further problems in the later childhood. For example, a 3-year-old who's refusing to go to school, mother may resort to some physical punishment or shouting at the child, or may also lure the child, कि आप school जाओगे तो chocolate देंगे और ये देंगे. So these kind of guidance the parent needs. So any parental concern, at least in my practice, I felt that it needs to be addressed, even though it may not turn out to be a disorder, but the way the parent is perceiving and handling the situation, the parent needs to be guided. So I think we have time and we can open up for questions from the audience. If anyone has, they can either put it in the chat box or unmute and ask.
महाराष्ट्र के मुख्यमंत्री बने हैं। पश्चिम बंगाल में फिर वहां खून दक्षिण ममता बनर्जी की पार्टी।
I don't think.
What advice was given to the first child when he didn't go to school?
The child with separation anxiety disorder. Yeah. So for the first child, what we have tried doing is the management, like what we advise for managing children who have anxiety, like giving them a structure and routine. We are also working on parent training, like giving them, teaching them, because the child is young. So we are teaching them techniques of relaxation, which they can try with the child, like deep breathing exercises, etc. So that they can calm down the child. Also telling the child beforehand that what is going to happen tomorrow or when the child is going to school. So if a child, especially this works well in anxiety, providing the child the information about what is this child is developmentally otherwise normal. So the child would be able to understand, okay, so this is a routine I'm going to follow. I go to the school, these things will happen, then there will be a break, then I come back. So giving them this idea. Also, we are trying to work. So this is a very, this child I've seen just few days back. So we have not yet to see the changes, but the plan is a gradual the plan is to gradually desensitize the child for separation anxiety, like short periods of when the child is especially gets more distressed if the mother leaves. So we are planning to start with short absence when there is another caregiver who can take care of the child, and then gradually increasing the duration. And also, when the mother leaves, we have asked the mother to make it a point that while she is leaving for work or while she is... So while the mother is leaving, when we are trying to desensitize, while the mother is leaving, we have asked her to make it a point that she says bye and she tells the child clearly, I am going and I will be back in this time, and Papa is there or some other caregiver is there to take care of you. So And gradually we are planning to increase this duration. So this will be something called a gradual desensitization, because this child is aversive to a parent leaving, especially the mother. So this is what the plan is for this particular child. So right now we are not considering any medications for anxiety, but rather than non-pharmacological interventions, and probably this should work for this child.
So
Hi, I want to ask you. Hello,
Yes,
I'm
I
Dr.
can hear you.
Shakdar. I want to ask you that most commonly, which we come across as a behavioral problem, is that children hitting a small child of 2 years, 2.5 years, 3 years, hitting other children at either at school or either at daycare. Otherwise, the child is okay. So a lot of the complaints which we get are from that. Particularly, this is called as daycare problem.
So if a
So
child,
how do you manage a 2-year-old? You know, you do all cases of positive affirmation to the child. You make the child understand what it means. It should not have a negative affirmation. It should all go for a positive affirmation. But still the child goes on hitting and comes back home and telling, oh, I've hit that baby today. How do you manage that? And I'm sorry and I'm sad. But then again goes and hits.
so we will have to understand. So like I said, every behavior has a function to serve. So we should understand clearly what was happening just before the child hit the other one. Was the child getting bored? Was the child not getting attention? What was happening immediately before this event? Just in the preceding 1 minute, we need to clearly understand what was happening, what triggered the event, and how we handled this. Whether the child was then scolded, the parents or the caregivers who were there. So what did they do? How did this behavior end? So every behavior serves a purpose, whether the child is seeking attention, whether the child has a sensory issue, if he's hitting out of the blue, if there are no, if there is nothing which is happening on a regular basis, but the child is hitting out of the blue. It can be a sensory problem, like a sensory processing difficulty. It can be an impulse control disorder, not disorder in a young child, but probably he might be at risk for something. So we need to keep an eye on the child's development, and we clearly need to figure out why this behavior is happening. Often this could be occurring out of boredom. The child is bored. The child wants the attention of someone.
It could be simply take some toy being taken away or something which the child wants, anything, and it hits with the aggressive behavior.
So we need to clearly understand what triggered, and then we can pinpoint what exactly could be the function that this particular behavior is serving for that child. And then only we will be able to work on the behavior once we know what is the purpose or what is the function of that behavior.
So it needs two people to reciprocate. First, say the daycare or school center where the teacher is there, she has to know how she's behaving towards each and every child, because her behavior also matters.
Yes.
Is her behavior proper, or how she's attending to that particular child emotional needs? Then the parent itself, the mother or the father, the care, whoever is there, and the child itself. So it is a triangle kind of a thing, I think.
Yes. So we need to clearly understand, maybe the caregiver at the daycare is giving some extra attention to the other child. Maybe this child is feeling left out.
Lonely.
Maybe the child wants attention. Even if it is negative attention like scolding, the child did get attention. So
do hyperactive children have this kind of aggressive behavior?
So often the early symptoms start emerging earlier. So lack of impulse control, I can say, can start emerging earlier on. But they can also be involved in hitting others, even though it can occur in a developmentally
normal child.
Normal. It can occur even in a child who is completely fine. But we need to address the behavior, because it is causing trouble in the setting the child is hitting another child. It is definitely something to be looked at. We need to actually work on this behavior.
Okay,
thank you.
Okay, I want to ask one question, which very commonly people, the parents ask us is when to start putting a child in a play school or a preschool. You know, how early can they put it? Because I don't know. I feel that maybe when we put them too young, also creates some anxiety in the child's behavior, something like a separation anxiety, because they're too young to handle it.
So yes, I'll just pass
yes.
on the question to Dr. Shubham to answer. So I was actually just trying to say when ma'am mentioned about the 2-year-old child hitting is a 2-year-old child attending a play school itself is too early, first of all. And I think one thing which we have to understand, how much is the language development of a 2-year-old child. Suppose he wants a toy, how well he or she can communicate to the other child about I want the toy, and he may just snatch the toy. So that could also come out as aggression. So Dr. Shubham, if you would like to answer Dr. Vandana's question.
Yes, like
Just can I intervene for a moment? I agree that 2-year-old child going to preschool may be a bit early, but with working mothers now, it's not possible at all because a lot of mothers send their child to daycare. So where is the child going to go?
So here what I was about to say is that we have to actually individualize this question depending on the family and their requirements. If there is no one else to take care of the child and at home, and if the child would be with a caretaker or caregiver at home, where the child would probably be engaging in much more screen time, would not be getting human interaction as much
as in a day, as with these other children.
So we
yeah.
have to look at what about the family dynamics. We will have to find out about that particular family when then only, because obviously 1.5 years and 2 years are early, but we need to understand that particular family, what their requirements are, to help them better decide what they want.
Because in some cases, interaction with the children of their own sort helps them a lot in their coordination, in their behavioral patterns, in their language acceptance. They start learning early.
So if
and they know how to associate with other children, play with other children. It helps actually a lot of helpful things also. They may have separation anxiety from the parent, which I feel gets settled down over a period of time. So this is the concept I'm looking at. Not that the grandmother or the caregiver at home takes care, or the mother doesn't work and she's there. That's fine. That's the best of circumstances.
Yes, so if there are people at home who can take good care and there is a good family environment, probably a joint family, then maybe we can decide accordingly depending on how the family.
Thank you, Vandana. Sorry for interrupting you. Thank you.
Not a problem. It is just that, okay, I do agree working mothers need to put their babies in daycare and all, that is fair enough. But of late, I have seen that it is a lot to do with competitiveness and further schooling with the ambition to put them in a good play school early and early so that the child is supposed to achieve more. So that is where the concern
that is not right. That I agree. That's not right at all. That should not be.
Because one aspect which we have to consider is the medical issues of the child, because a lot of children who start very young may be very prone for infections, recurrent URIs and all, and which probably that is why we say 2.5 onwards is the age for play school, because the child's immune system is more developed to kind of mingle with other children and be there. So those things family has to seriously consider, but obviously each family and each needs are different. So they have to make that informed choice, I would say.
Yeah, I think 2 years should be ideal in that sense. 2 year, 2+ in a way. Even for working mothers, I think 2 years should be okay for them to send to daycare.
For single unit families, maybe early schooling is better because the child is totally alone at home.
Yeah,
and the parents are both on the laptop.
I think what she has said is quite right, that it has to be individually. You have to see how the family is there and how you can manage it. It's a difficult choice for everybody at the end of it.
Yeah, but they
I have
ask
an
us
interesting
for the
question,
guidance.
Dr. Shubham. Dr. Shubham, thanks for a very interesting lecture. How to deal with a child 10 years old who has excessive fear with cat or dog?
Yes, so like this kind of symptom which you are mentioning, it could be probably phobia, or it will fit into a phobic disorder. So which comes under the anxiety disorder group. So here for a 10-year-old child, the line of management could be screening the child for anxiety and confirming the presence of a phobia. Then what we can do is like this, we can start interventions like cognitive behavior therapy, which and also gradual desensitization for this particular child, like gradual exposure to this child. So a CBT, a 10-year-old child is cognitively well enough, or the child can understand so his problems, and it will be so a therapist can work directly with the child to guide him and work with the child with like gradual desensitization. So we can use a CBT technique and gradual desensitization to work with this particular child.
Excuse me, ma'am.
Yes, I can hear you, sir.
Yeah. How does the parents' overprotectiveness and over clinginess to this competition will affect kids' overall behavior?
Yes, sir. Like I said, that the family dynamics and the family environment is, as well as the parenting style, is very important, because we need to clearly understand this. So now usually we call these kind of parents who are always there hovering, so helicopter parenting, where they keep an eye on everything the child is doing. So the parenting style can definitely affect the behavior. However, I would need more information on the child to know better. But yes, it does affect a child's behavior.
Okay. Thank you.
I think there is no more questions. Thank you, Dr. Shambhavi, for being chairperson. And it was a nice presentation, Dr. Shubham. Dr. Shubham has been all over India, from Ranchi to Karnataka to Mumbai, Kerala. Now she is settled in Delhi.
Northwest, east, west, north, south, all covered.
So few of the doctors from down south also have joined, I'm seeing. Thank you. Thank you all the audience for joining. Good night. Good night.
Kindly keep on doing this type of CMEs, especially these topics are never discussed, especially developmental pediatrics and behavioral pediatrics.
This is the third actually. This is the third in this with us.
In last 6 months.
Isn't it?
Yeah,
in the last 6 months. Still people find it so interesting. And Dr. Shambhavi also really takes active interest in all the topics. I remember last time I asked a lot of questions and he was helping us out. That's why I remembered her.
Dr. Priya Jain also have joined.
Yeah,
She was also there.
It's good to have all. And one more thing is all female this time presenting and all. That is very great to see this. Nice to see all of us.